past and all that, or maybe a relative or someone had a problem like this. We're going to talk a little bit about our evaluation, how we look at shoulders here. We have a slightly different way of looking at shoulder problems and treatments. Sometimes we'll also discuss a little bit about the influence of the neck on shoulder problems. Occasionally, some of our shoulder problems are really neck problems. We're just kind of in disguise. So that's kind of confusing for the therapist sometimes, and also for the patient especially. So I've had my own shoulder problems, which we'll talk about a little bit, some personal experience, and I'll tell you a few stories that were a little scary, but had a good ending about my own problems with shoulders. But it's been exciting. It's probably one of the areas that I treat everything except for the hand. I always say I don't treat hand type problems, but I treat everything. But I would say shoulder and spine are some of my favorite areas that as far as treatment. There's been some really interesting advances in understanding shoulder problems in the last few years. So I hope to shed some light and kind of, if there's any questions, please just don't feel bad cutting in. If I don't get to it right away, I'll take a pause and all that. But we'll start with that. But if anything you want to talk about, please just jump in. So let's go and just hit the buttons to the side. No.
It's just moving.
Let's go like this. Okay. Just go like this. Okay, so we're going to do, she's going to hit this right here. Okay. So we're going to understand a little bit about the anatomy of the shoulder. We're going to show you some pictures of a tendinitis, frozen shoulder. We're going to understand some common shoulder problems like we discussed. The method that I talked about, the McKenzie method, is a particular way of approaching shoulder treatment. And if you've had a lower back problem or neck problem, you might have heard of this particular approach to. It's more associated with like lower back problems, but the method is actually used for all the joints. Okay. I'll give you a few tips on prevention of neck and shoulder pain, a few basic exercises that we give here, some of our common exercises that we'll give out for shoulder problems. And if you've been here, and I know some of you have for shoulder problems, you'll kind of remember some of them, and some of them will be kind of new probably. So what are the risk factors? Some of the risk factors are, quite frankly, past history of shoulder injury. Similar to lower back, if you've had a past history of an injury, a trauma, a fall, oftentimes that area will come back later on. We do, unfortunately, age a little bit, and some of those tendons, when they have a tendinitis in the past, they may eventually advance to a tendon tear, more degeneration, or further complicate the problem. We also can develop arthritis. A lot of these things are age. We use these terms, but they're age-related changes in our body. So these terms get a little scary, but we're going to talk a little bit about that. Laborers, carpenters, cashiers. We think about laborers, carpenters, cashiers. That repetitive motion can be a real hard thing on shoulder problems. I don't know, that constant reaching forward, also neck as well. Hairdressers. When I go to Supercuts, I always talk to them and I go, how's your shoulders and neck feeling? Because it looks like that must be hard doing that all day. That elevated position, they're pretty good about changing the height. They've got good mats on the bottom, but it's still kind of hard. It's that upright position. Typically, if your dominant arm is at a greater risk for problems, which is pretty intuitive. But the interesting thing, when you have surgery on the dominant side, it gets better faster because people just naturally want to use it. So they tend to get a little bit better when they have the dominant side. When someone has an injury on the non-dominant, they tend to kind of neglect it, and they just don't use it as much, and it just doesn't get better as quickly. So they've also identified weekend warriors, the class of people that are going out and they're going rock climbing on the weekends, but they're pretty sedentary during the week. They're really not doing a lot to get ready for those activities. They can also be those people that are, fixer-uppers. They take care of the house a lot. They do a lot of very physical work on the weekends, but during the week they're kind of sedentary. They sit a lot. They just don't move around as much. I always say they probably have to do more prep to play. They have to do more preparation for those physical. I was just moving the ladder the other day, and I work out and all that, but it's still pretty hard to get that into position and manage it. And I could easily see straining myself with that. So those are some of the things we have to worry about. Obviously, our high impact sports. Sometimes they're not meant to be high impact. Sometimes you have a fall on an arm. But other sports in the past, if you've been involved with a contact sport, even soccer, football, where you're constantly getting that repetition, it kind of wears the joint down a little faster than someone else that's not engaging in that type of activity. So, and extensive keyboard use. I talk about this a lot with people for neck and back problems. They're just sitting so long. But that frequent use of moving the mouse and leaning forward and different programs, it is kind of hard over time on your shoulders sometimes, and we don't really think about that. Sometimes we'll talk about carpal tunnel, but it is something that can cause a problem. with our keyboards and our IT people. So there's certain things that you can change in your workstation. OSHA actually has a whole thing on ergonomic and computer workstation setup that I talk about. And it talks about the angle of the monitor, the mouse. I use a roller ball in my office, you can even see, and that's kind of nice. You don't have to stretch as much with the mouse and kind of reset it. You just kind of roll that ball, and you don't have as much excursion with your shoulder. So there's some of the little things you can make it a little more comfortable for your day if you are doing a lot of work. Nice thing is I'm up and down all day. I'm kind of standing and sitting, so I've got a great job. Probably the hardest thing for me is my neck as I lean over people, and I'm doing this a lot, or I'm leaning forward, and that can cause some problems for me. So let's go forward again. Nope, the other way. Okay. Next. Nope, okay, next one. So some of the common shoulder diagnoses that you'll hear out there, I'm sure you've heard this before. Let's go through a few. Is a rotator cuff tear, frozen shoulder, also known as an adhesive capsulitis, shoulder impingement. You can have labral tears, arthritis, AC joint OA or osteoarthritis, or shoulder tendinitis, bursitis. And you'll find certain age groups fall into these different categories. Our labral tears can be traumatic. You'll see it in the younger population. They're also with our dislocations, or folks that dislocate their shoulder, younger individuals typically. Arthritis, as we get into our plus 50, we'll have our changes to that joint surface, and that could be a source of problems. Sometimes they'll clean out the joint in like surgical cases, or they'll actually do a joint replacement, and they actually replace the whole joint in the shoulder, which you don't hear about as much. You hear about the knees and hips more, but that's some of the solutions for arthritis in there. Sometimes it's a joint replacement. Sometimes they'll say, I'm cleaning out the joint. It's like cleaning your room, kind of smoothing everything out. AC joint OA is right on the tip here, that little tip of the shoulder when people come in. Sometimes it's from a direct fall on an outstretched arm, or right onto the actual tip of your shoulder. And you'll see people with this sometimes will have a slight step off. It looks like there's a little step on their arm, you'll see. And it's when it actually separates. When they talk about a shoulder separation, that's what you'll see on these folks. And our younger individuals, we'll talk about a shoulder tendinitis or bursitis. Now, itis, just to clarify, is inflammation. There's a bursa or a tendon, and there's swelling in there. You're hearing the term tendinosis more, which means there's some loss of blood supply in the tendon. And there are people that it's over 2 or 3 months, they still have pain in their shoulder. Why is there still inflammation in there? Okay? And they have lack of blood supply, and what we're trying to do is kind of get some blood going so it actually starts to heal the tendons. So itis is more initially when it first happened, you went ahead and you played tennis and you hadn't done it in a while, and you're like, wow, it's kind of sore. You stop doing it for a little while, it goes away. The tendinosis is you do it, you stop, and it still persists after a long time, and it's still there. So there's different types and different age groups you'll see these folks in. So, next slide.
What is
Stop for a
frozen
second.
shoulder?
We're going to go right into it, actually.
Oh,
Yeah,
okay.
We're first going to talk about rotator cuff tears here, okay? So there's a series of 4 muscles that make up the rotator cuff, okay? Supraspinatus, infraspinatus, I'm not going to quiz you, teres minor, and subscapularis, okay? The one that you'll hear the most about, the tears are most common, is the supraspinatus, okay? And that's actually where you have a lot of your tendinitis in the shoulder. That, and I would say the long head of the bicep. But this is part of the rotator cuff musculature and actually showing more of a front view. This is if I was standing like this. On the other side, you'll see the other parts of the rotator cuff, but the top right here is the supraspinatus right there. And it attaches to the humeral head. So this bone right here. You can see in our skeleton right there if you look over to your left. And right around here, when we have a tear, we're looking at more like our plus 40 or plus 50 age group. We'll have a little separation or tear, sometimes a partial or full thickness tear, right in that area, right in that tendon. If it's a partial thickness tear, it's a little bit more successful with conservative treatment, as long as it's like less than 50%. If greater than 50% of the supraspinatus, that tendon that runs all the way, like on me, it would start, it's below my trapezius, this muscle on the top, it's deep, goes through and kind of attaches here. They'll get pain kind of off in the side here, sometimes towards the back. But God, it really hurts here. Especially hurts when I go to the left, or when I reach to the drive-in, I'm trying to get to the teller machine. That lateral movement's very hard for these folks. So that tendon separates, and then what happens is these 4 muscles are supposed to help the humeral head stay in the joint, and the shoulder joint is very shallow. So it needs those muscles to kind of steer it, all right, and keep it in the joint. When they don't, it tends to impinge and hit the roof. It's some of these bones that make up the roof of the shoulder. So you have a little tear there, and in more extensive tears, you can have, you can get all 4 muscles of the rotator cuff torn, but that's a very, you'll see that in more the plus 70 age group. It's just not as common. But when you have tears, this is the spot right there. So that's a rotator cuff. There are a lot of people with rotator cuff tears that don't have symptoms. They did this great study they did 300 women, no history of shoulder trauma, no current pain, and 30 to 50%, and there's a few studies, actually have tears. So the question is when do we go ahead in there and surgically repair it? And when do we say, maybe we should try and let a little time, or maybe some conservative care, PT, chiropractic, acupuncture? When do we do that? When do we select our candidates? So that's one thing about the rotator cuff is kind of when do we identify our surgical candidates, and when do we get concerned? The full thickness tears are more of a concern, which we'll talk about more maybe a little later on. Those are more concerning. The partial thickness tears, a lot of people have them, and some are just related to age and breakdown. The same people have a little arthritis, they'll have a little bursitis, they'll have a bunch of things. It's like a little things that aren't going great within that joint. But they're not necessarily the pain generator. It's like which structure that's not great is the source of my pain. And that's not always clear. So let's go to the next slide. Now a frozen shoulder. Now there's a capsule around the shoulder. So this doesn't show all the muscles attaching to the humeral head here. This is the scapula, this is our clavicle, our collarbone here. So this capsule right here is a normal capsule, okay? And when the shoulder moves, if we can we get the shoulder model actually, someone can do that for me? The shoulder model right here. This capsule, when the shoulder moves, and go over here, it goes down and uses the bottom of this capsule to kind of create some stability at the shoulder. So when the shoulder dislocates, this structure, this capsule loosens in people showing dislocations. But in people with frozen shoulder, I'm going to get that model in a second. Here we go. I'm going to dislocate this model. Here we go. Okay, this is a right shoulder. In the case of a frozen shoulder, this actually starts adhering. It starts becoming smaller, and they don't really know why. It's kind of something that gradually occurs, and it shrinks. Very, very painful. Very painful. And you'll find is that as the shoulder moves, since it doesn't have this area right here shrinks and it's not nice and open like this right here, the shoulder impinges and it can't move as well. It's a very mechanical thing. The first 6 months, they call it this freezing phase. It slowly shrinks. It's very painful. Ice kind of helps it during that period of time. Then it stays frozen. It stays tight for upwards of a year to 18 months, and then eventually thaws. That's why they call it the freezing and thawing. And it's very painful during that period of time. You'll see people that they literally can't move in very severe cases, especially out to the side, sometimes past here. And this gradually comes. So just you gradually say, I used to be able to do that. That's a little tight. Maybe I'll move a little less, and they slowly lose the motion. They typically are pretty strong, but they have a fair amount of pain, a fair amount of night pain. So, and that's any more questions on that? Yeah. Yeah, it's not a fun thing. Don't get it. And it's very hard to treat because it's a very painful condition, and it's very hard to stretch out that joint to regain that mobility. So we'll talk about some of these things. Frozen shoulder, rotator cuff, we're going to go into a little bit more. Those are some of the common things that we'll see here. So now when you talk about a tendinitis and bursitis, I use those terms. We also talked about tendinosis earlier. You have the acromion, you have this tendon here. You've got some of the ligaments that cross right in front of the shoulder here. You have a bursa right here. And then it shows the tendon a little bit more clear. That's that supraspinatus tendon I was telling you about. This is commonly where that tendon tear is, and it's also where you'll get that swelling and inflammation, that younger tendon, okay, which can be a source of pain. And that's when an anti-inflammatory may feel better, little ice, little rest. That starts feeling better when you have that inflamed tendon in the younger individuals. The other case is you can have a bursa. Now this fluid-filled sac, you'll see in certain people, like you ever see someone that's got this big swollen, almost like a tennis ball in their knee that swells. That's another type of bursa, and that's supposed to provide a little cushioning around the bones. Okay, but occasionally it gets irritated, it gets swollen, and when it's in the shoulder, it's so tight in there. When that gets enlarged, it creates a little space that's hard to move around, almost like a crawl space. You're trying to move around. You're moving around. You're hitting all different things here. There's not as much room with this bursa swollen, and when it goes down and lets swollen, it'll drop in size. So that's when you think of bursitis. And there's other bursas that are around the shoulder that we can talk about, but it's the concept is that gets swollen and creates some problems. And the other one is tendons. Next slide. So the big risk factors for rotator cuff is a history of a trauma. I've had a few falls on mine that early on when I was younger, you know, playing football and other things, skiing. Some of it is more just related to age. You're a little older, the tendons don't have the same flexibility, more brittle. They don't have the rich blood supply of the younger tendons. And also the dominant shoulder. Those are some of the clear risk factors. Next one. Okay, so we have someone here that have been willing. Linda M., we cover privacy. Linda has had, do you want to stand up?
I look like a rotator cuff.
You look like a rotator cuff, but you look like more like a
What does it look like?
So basically, Linda and I met a long time ago because I helped out her daughter with some things.
Several times.
Several times.
Yes.
And she came to me after saying, I've had this shoulder problem for quite a long time, but it's recently got worse. Okay. And we talked about it and all that, and she showed me her MRI. Can I talk about your MRI? Do you want to tell me about your MRI?
No.
Okay.
You know, you are pointing out things. I didn't want to know anything.
I know.
just
Linda would have been
heard
happy not to
complete
know.
tear, and I thought, oh, okay. And then I didn't, you know.
So I said, listen, you've got a complete tear there. It's been going on for a long time. I had the pain for a long time.
Oh,
And she had a full thickness tear. And what we found is we said, listen, let's see what we can do. You know, sometimes these you can get back to a reasonably good function. And some of the goals that Linda had was to go back to tennis. Her dominant side is the left side. So it is a little bit easier as far as, but you still use it. And all that.
Yeah.
Playing harp is something that she likes to do.
Right. I play a small harp, a therapy harp, Celtic harp. So it's carried on the shoulder, but it's carried across the right shoulder. So that was a distinct problem for me.
Yeah.
That and putting on my clothes and doing anything else,
Yeah,
because it was so excruciating.
Yeah. And where was your pain a lot when you had experience it?
It was very much on this part of my arm up into my neck.
Right.
So it was across here into here, but I couldn't, you know, in putting on your clothes and just doing these, it wasn't even so much the major moves.
Right.
It was very small moves, holding a plate or cutting something, holding something to cut. So I gave up cooking, which it was so difficult for me. No, but it's, these are things that you need to put your clothes on every day. You need to cook things every day. So I kept thinking, oh, it'll go away, I'll just get better. Yeah. And then finally I did go to a doctor and he sent me for an MRI because I was in tears. Yeah. You know.
And the hard thing was it had been around for a while, so unfortunately it was probably something that was going to be very hard to really repair almost.
Right.
You know.
Right.
So we said, let's see what we have, let's see if we can improve your function.
Right.
And we took her through an evaluation. We found one exercise we gave her that really made a difference. And she remembers it more and more now as it gets because since it is something she's always going to have, she's probably going to have to go back to this exercise. And I say, try to remember, blow off the dust off your home exercise sheet, and try that exercise again and see. And it seems to help her. And then after we got to a point, we said, let's start giving you some strengthening exercises, trying to compensate around there, and that really has made a difference. But it does go out. I mean, it does. She does have problems with it, and then she has to go back to them. It is more cramped, but a lot more function. You feel a lot better. You know. So
I have almost complete function.
Yeah.
In fact, I can do this, which there was no possibility. Now I don't want to do that very often, and I don't have a need to, except when I'm thinking other drivers when they let you go through. You know, I used to have to go like this. I don't know what they thought I was doing in the car, waving to them like. Okay, so I basically can do everything, but as Tom said, it does still go out because it's not, you know, it's detached. But now at least I have, you know, some exercises that he gave me to because it hurts when it
painful
does.
With it,
you know, but also you suggested that you actually use it.
Yeah.
You know, that because for months I was trying not to use my arm at all. So the fact that now he's, you know, okay, if it can hurt and you can get it not to hurt.
Yeah.
And I now know how to engage the muscles in my shoulder blade in the back without even having to come and do some of the exercises, to just try and I never realized I had muscles back there before he found them for me. But what a difference it just has been night and day. Yeah. So
and she's a good patient. Like, she really does the exercise. And not everyone's turns. I'm not going to say you know, like this. You know, everyone's.
Well, I'll tell you when I didn't do the exercise. I didn't do exercises.
But yeah, it's just something that. Yeah. But it's a good example. You can have these full tears and have some resolution. It does matter. One of the things that Linda did experience too is she was trying to work on, people commonly have like a shrug sign in very major tears, and that can impart a lot of pressure to your neck. So she started developing a lot of upper back pain. So we gave her some neck exercises too, because the problem is that you get into this compensatory pattern, all these muscles that attach to try and compensate, attach to the neck.
Right. Right.
So we gave her some neck things. So it is something you got to be a little careful about, and that's that neck and shoulder. Which one is it? And you kind of had. She loves it. She had both. Unfortunately, she was an overachiever, and so we had to give her both. But it's just a case. I like to give up a real example of like a rotator cuff tear. And listen, some people do have to do surgery. Some people say, listen, I want to go rock climbing. There are cases where they have to either give it up or they have to get surgery.
If this were my dominant arm, I would really consider. You know, maybe if I were younger and could get a few more muscles engaged. You're at 65, it's not so easy to get all those muscles, you know, engaged. So, but certainly for my non-dominant, and I do play tennis, I have a two-handed backhand. I want to toss for my serve, and I also want to play the harp. And that requires having it sit on my shoulder and using my right hand while I'm standing up. It's not that I'm sitting down. The whole, weight of the harp is on my shoulder. But I had complete faith in Tom because my daughter is a competitive baton twirler, internationally ranked, and he brought her back. She had a knee operation and a shoulder operation. She had one a year ago, and she's headed to Croatia this summer for 2 international competitions, and it wouldn't be without this gentleman.
All right. Well,
I want to give a testimonial because I say that's on. But no, what a difference, because she had been to a number of different places, and really with Tom you get absolute individual attention, and other places it's like a mill. I don't think they knew what her problem was. I don't think they cared what her problem was. It was she was number 43 for the day, and that was what a difference it made. It really was night and day. And for me it was night and day too, because now I basically do you see I have my clothes on today. So I can really do almost everything, and it does go out and it does hurt, and then I do some of the exercises and I try and engage the muscles. So
well, thanks for sharing your story. I'd like to hear about that, and so you can see the full rotator. So I'm excited for her, and that the part of the job I love. I love that she's feeling better. So we heard about frozen. So frozen shoulders. Some of the risk factors are people with diabetes, thyroid problems, females over age 50. You can read through this. A fracture. If you've just had shoulder surgery. Parkinson's, cardiovascular disease, stroke. So all these are some of the things that if I see someone come with a shoulder problem, I go, be careful, it starts getting tight. Even if you don't come to me, just be aware if you start all of a sudden you're slowly losing your range of motion. These are some of the high-risk groups, especially the people with diabetes. You really got to be careful with them. And they just don't, when they do too much, when they overdo it, they tend not to recover as much. So they've really got to be very careful with the patients with diabetic conditions. So some of the comparisons here we talked about with the frozen shoulder. Make sure I get out of my screen. You get a real shrinkage of that capsule that we showed you. In the rotator cuff, we get that full tear, sometimes a partial tear of the tendon. Our frozen shoulders, it'll sneak up on you. You'll kind of gradually start getting some problems. The rotator cuff can be traumatic, or it can just gradually come on. So it's a little similar in that sometimes it doesn't happen with necessarily a trauma. But when it gradually comes on, it's a little easier to treat. The traumatic ones don't do as good as the non-traumatic. So if you had a gradual, I was just doing some guarding, it kind of slowly came on. That's better than I fell on my shoulder and all of a sudden I couldn't lift my arm. Those are a little harder. Not that they can't respond, but they're a little typically harder statistically.
Tom, can you have both?
Yes, that's great. You can have a combo shoulder.
I think I might fall in that category.
Yeah, you can have a trauma. You protect it, kind of like what Linda was saying with her right arm. She stopped moving.
That's when I was in high school. Yeah, it didn't bother me till I was 80. But
yeah, sometimes you can have that previous.
Yeah.
You lock it down, then it starts getting tight. And internal medicine people used to have people come to them for a shoulder, and they repetitively sling them. They put them in a sling, and they would develop a lot of tightness because they didn't. When did I take off the sling? And they get tighter and tighter. Not everyone. Some people would just stop using it. Other people would continue to use it, and they develop a tight shoulder, which can be very, very painful. So yeah, no, you're right. You can have a combination, and you'll see that with post-surgery. That's why they want you to move it pretty early. They used to protect it for 2 months sometimes. Don't move it, and they developed a very tight shoulder. They would rotate. Sometimes they repair the rotator cuff but then they're like, great, the rotator cuff is perfect. And now you got a tight shoulder. It's almost, the function is almost the same. There's not a great deal of function. So the frozen shoulders will last about 12 to 18 months, sometimes upwards of 2 years. In a natural course, it typically gets better. They show physical therapy will typically help it a little bit, but not always. Some people, if you're too aggressive in the early, like first 6 months of the frozen shoulder, you can actually make it worse. So if you go, and I was young and I was first out of school, and you're really trying to aggressively treat these people, I want to stretch them, I want to get them better, because that's what I do, you can actually make their condition worse. Sometimes they can benefit if someone has something they're really having trouble with, a manipulation, they knock you out, nothing I'd want to do, and the surgeon moves the shoulder and loosens it. There's some pretty good outcomes with that, actually. They can actually do an injection, a cortisone injection. Sometimes that'll loosen it up for you as well. So there's other approaches that you can do that may help you if you're really in that point where you're just not functional. Because there's different levels of frozen shoulders, like anything in life. So be careful about that aggressive therapy in the early stages. Does the rotator cuff heal? No, it doesn't. You still have a rotator cuff tear even though you don't have pain and symptoms. Okay, so the idea that you went to therapy and it healed is not correct. It just doesn't, it is not painful. You may have a little loss in function, but it's still going to be seen as an MRI of a torn tendon. So that's why we talked about those MRIs showing tendon tears. We got to realize they're still there. It's just your function, you're compensating, you've got good mobility, and you're all right. And we talked about earlier is the smaller, less than 50% of a partial tear, they typically respond to physical therapy or just rest. You know, if they're not, some people just get better. Like I'll be the first to say, a little bit of rest. But over 50%, it gets a little harder, especially when you get into the full thickness tears. So when do I see a doctor? When do I say, I'm going to see Tom, he's just going to send me to the doctor. You have a sudden loss of motion. All of a sudden you go, you have the fall, and you literally, and I had this experience we'll talk about later, and I can't move my arm away from my side. You want to rule out a fracture. You want to make sure there isn't something that's really, truly needs to be stabilized. I think that's pretty obvious, but there are people that come in here and say, what happened? I say, you can't move your arm, you got to get an MRI or at least a basic X-ray. Progressive weakness. Sometimes you'll have what presents to be a shoulder problem. You say, that looks like a rotator cuff tear. And it's related to like a nerve in your neck that's been pinched. And it seems like you can't move it, but it's not related to the rotator cuff, just the nerve going to the rotator cuff has been pinched. And it actually affects the motor function, the ability for those muscles to fire. So that's a very, and it's getting, and the other thing is it's not just weak, it's typically getting weaker and weaker. Numbness, burning, and tingling below the elbow, which is similar to the neck issues I'm telling you about. Below there, we'll get more concerned about neurological involvement. Unexplained weight loss, that's the I wish question, unexplained weight loss, that's my standard PT joke. No, I know why, I don't know, there's no reason why I lost this weight. That could be cancer, something more systemic, or something that you should be more concerned about. Recent trauma, like we talked about, fall, motor vehicle accident. Unfortunately, when we get a little older and you have folks that have osteoporosis or osteopenia, they actually don't need as much of a trauma. Sometimes it's just a little jolt, and they may develop a little chip fracture or something that you wouldn't think would cause a problem. So sometimes you have to be a little more careful, especially if you have osteopenia, osteoporosis, with those little things that don't seem a lot or wasn't a big event, it actually creates a big problem. Severe constant pain, that's right up there with unexplained weight loss. It could be cancerous, it can be a tumor, something that's just physically causing it. We're talking unrelenting pain, not just you roll over and that's painful. It's really, really painful. This is more a stroke thing, difficulty with speech. All of a sudden you're losing function in your arm. You look at your dad or mom, you're like, wow, a little saggy, speech is a little bit off, and now they're having a hard time moving their arm. You might be looking at a stroke type issue and something that you want to really identify quickly. But sometimes it's hard. You're on the phone, you just say, are you mumbling? What's going on? How my shoulders bother me. Okay. So we talked about this a little bit. I'm just going to talk about it again. We talked about when you look at MRIs and arthritis, the MRI, most people who get an MRI, the internist will sometimes order the MRI. You get the results before the doctor can talk to you about it. And there's a lot of changes in there. There's a lot of things that have kind of gone wrong in that shoulder that'll show a little arthritis, it'll show a little tearing here, it'll have spurring, it'll show inflammation. There'll be different things in that MRI. And in addition to arthritis too, there's a lot of things that are just age-related. In fact, we can develop arthritis as early as age 20. in some people, especially someone that's had, you know, contact sports or trauma. So some of it is just age-related. It's just our body kind of wearing a little bit. The question is when is that related to something that is our pain generator, something that we need to actively treat? So we have to be careful about weighing this in, and I always say you've got to take the MRI, which is a picture, and pair it with how the person's functioning. If Linda came to me and just showed me her arm motion, I would say, I don't know if that's a full rotator cuff there. She's kind of elevating it pretty good today. Maybe until I test her strength. Oh wow, that matches her MRI. So let's, and also what she tells me about. You know, I have a hard time reaching to the side. The rotator, they'll have a lot of night pain. Oh, that kind of makes sense. The whole picture makes sense now. So I was kidding, please don't get scared of your MRI results until you talk to someone about it. You know, because the people the radiologists that make up the MRIs or give you a report on it, they talk about everything that's there. You know, so the MRIs are good about telling you everything in your body. That's why I have a problem with the whole body scans. You always have things that are not perfect in your body. Are they really the cause of concern? You know, so, all right, let's move forward. So I usually, this is a pain diagram. It's something from the McKenzie Institute, which doesn't really matter, but neck and shoulder pain can sometimes appear the same. So if you look at this diagram, it's showing the movement of pain. Occasionally you'll get pain in the hand or elbow, shoulder. That can be related to a neck and is similar to a rotator cuff problem. I've had people that have said, I've had very, very severe elbow pain here, and they actually didn't even have shoulder pain. And I'll say, wow, I said, you know, how's your shoulder, how's your elbow? Oh, elbow feels good, I can grip, I'm fine. But their shoulder mobility is really affected, so it can refer and give you pain that's originating from here, and it can go down the arm, tingling, numbness, and such. It's not as common to go below the elbow, but it can occur, you know. But in the same respect, you can have neck issues, especially when you start talking about problems. So from here over, when you start getting to the scapulary region, from the shoulder blade over, I start saying, this sounds like it's a little neck issue too, okay? So it is something to consider. It tells you how pain can move. If you have a neck issue or shoulder issue and the pain starts moving like more to the source, you can see how the pain kind of travels as time elapses or treatment, and it goes more to the center, and then it becomes more clear sometimes. You're like, wow, that shoulder pain is there, but now I've got some neck pain. Oh, this is a neck issue. So if you're interested, I was taking a course recently, and the instructor said he had a couple people with rotator cuff repairs. And they said, I have the same pain I had, it's been 6 to 8 weeks, same pain I had before surgery. He goes, can I move your neck around a little bit? And unfortunately, they said, well, that feels a lot better from moving my neck. And they really had more of a neck issue. They did have a rotator cuff tear, but unfortunately, that was not the main pain generator. So we got to be really careful about, I call clearing the neck, make sure the neck isn't involved at any time. So this is me in Barbados surfing, 2004. No, it's not. This is what I think I look like.
Crazy, you're not that crazy.
I'm not crazy. I'm not that good. This is someone I wish I was for like one moment before he got hurt. But actually, the second, that's actually me. That's actually what I look like too. I'm really not a good surfer. So anyway, I mentioned this. I was in Barbados in 2004, and I was trying to surf like that, and I wasn't very good. And I got knocked over by a wave, maybe a little bit bigger than that. I landed on my neck and my shoulder. And I was there, and my wife was pregnant. I had just signed the lease to this place. And we were moving to Tendinitis from Brooklyn. I think I got it all. And my father-in-law was helping out with renovations, which was kind of stressful. So I'm sitting there, I get off the beach, I just landed on my head and my shoulder. Sue's out to here with our first boy, Ryan. And I can't move my hand to my ear for about 4 or 5 days. And I'm a little nervous, and she's got a poker face. She goes, you'll be fine. And the baby starts moving more, you'll be fine. And I go home and I see a local doctor I know, Ray Longobardi, which you know. Yeah. And I say, Ray, I got this problem. And he goes, well, you've got a partial rotator cuff tear, you got a labral tear, and you got a biceps tear, and you probably need surgery, but obviously you just started work. Let's see, you just opened this new place. I had 4 patients on a week at that point. You probably have to wait on it. And I said, gosh darn, okay. So over the course of time, I did a little self-treatment, and you know, a couple of my friends that are therapists helped me out, and I slowly regained motion. What I don't know, because I had a positive MRI, I don't know if the neck involvement was part of my problem at the time. And I mentioned this case because I had neck issues when I was a kid playing football, and I had problems elevating my arm during that time. And I still don't know, is it related to, was that incident related to my neck or my shoulder? I really don't know, but it did get better. I'm lucky. I haven't had surgery yet. I've done a lot of things. But I always wonder if someone looked at my neck, if I would have gotten better a little faster, if that was part of the problem, because it was such a dramatic change. It was a partial rotator cuff tear, it wasn't a full tear. And I've got pretty good motion. It does give me problems. I mean, Kathy could laugh and she's like, "Oh, you got your shoulder out." I'm like, "I'm doing this. I'm trying to do all these stretches." So it does bother me. And it wasn't that exciting of an injury compared to that other wave. And I'm still surfing about that same ability right now. But it's fun. But it's definitely something I always wonder about what was going on with my neck. So our evaluation, we go through a thorough history. We talk to you. That's the most important thing. You know your shoulder better than us. We're just trying to get to know you. When did it start? Did you have a fall? Did it happen gradually? Is it constant or intermittent? Sometimes constant means there's like chemicals, it's swelling, it's typically during the early stages. What's your job like? Kind of what do you want to go back to? Like Linda said, if it was my dominant side, I might have gone for surgery, but it's non-dominant. I can play tennis, but it's my non-dominant. Maybe I can get away with getting this rehabbed. Are you taking any of the medications, and are you receiving any other treatment for this now or before? Just to get a sense of where they've been. Some people come to me from other therapists. I love it. Tell me what they did. I won't do that. You didn't get better. It's not against that therapist. And also, you have a little time that passes by, and I learn from other people. Wow, they did this and this. I really got aggravated. Well, maybe I have to take a little more care with you. We got to go a little slower with your rehab so we don't flare you up. And it tells me a lot. The other thing I'll talk about, just as an aside. One thing you want to be careful about is if you're getting treated by a chiropractor or a physical therapist, nothing against chiropractors, make sure you're clear on who's making a change. Like sometimes they'll say, go to the chiropractor for a while, go to me, but don't do both, because it gets a little confusing sometimes. That's just a little something that I've learned through the years. It just goes, are you getting better because of me or him, or I don't know. So the other part we do with our shoulder evaluations is we like to clear the neck. So let me show you, we just do a quick series of 3 tests. We don't do it with everyone, but if I'm concerned about the neck, let's go ahead. Can you come over, Franklin, for a second? I'm going to show you, it's a series of 3 tests, and I want to see if it reproduces the pain they're coming here for. Let's have you turn, you're going to face that way. The first one, we're just going to check their posture, and they're going to say, okay, I've got pain in my shoulder right now. Okay. Just tell me if that gets worse or better when I have you do this motion. So you're going to pull your chin all the way back. I'm going to hold it there for a couple seconds. Make sure they can breathe. Okay. All right, that feels okay?
Yep.
Great. So you're going to pull your chin in, and then you're going to look up to the ceiling. All the way up. Up, 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 as far as you can. Any pain with that at all? Anything into that shoulder changing at all? No. Okay. The last thing we're going to do is you're going to take your hands, you're going to interlace your fingers like that. Pull your elbows together. And we're trying to check the upper thoracic, because that can give you pain into the shoulder as well. We're going to lean back. Any problem there? Nope. Okay, that's good. So those are our 3 clearing tests for the neck. Pretty quick. If I start getting some mixed things, like, I don't know, I think that's starting to cause something into my shoulder, I may do more. If I have someone I really think is a shoulder issue, I don't do this. Okay, but that is one of the things we'll do. Especially if you have someone like Linda who's starting to get a lot of scapular pain in these areas, I'll say, let's take a look at that and make sure we're not missing. Because you can have both. You can have a combo. And that's just something just to be aware of. So we go through some movement testing. They call it loading strategy. I'll show one that we commonly do here called a crossover stretch. What I want you to do is I want you to pick your arm like this. So tell me, you have like a level 5 pain right here, let's say. You're going to move your arm across, pressure on, to the very end, pressure off. A series of 10 times. And then we'll say after the series of 10, does it change your pain? Does it make it worse? Does it make it better? Sometimes if they have pain, they say, I feel great today. You really look for movement loss. Like if they have a very big difference from this side, wow, it stops right about here. This side clearly goes across. I will go by that loss of motion as a sign that I want to address that range of motion. There's certain directions that commonly help people with shoulder problems, and there's certain ones that are less common. I normally start with the most common one is shoulder extension, which we'll show later on, crossing over, or forward elevation. There's 3 that commonly help people. If I call my uncle from Texas and he has a shoulder problem, I show him a video of me doing this, and he tries it and sees if it gets better. But those are 3 things that you would not commonly see. Once we get some control of the symptoms, then we'll add exercises and strengthening at that point. And they call it loading strategy. We're loading the joint, whether it be in any other direction. We want to know if that condition, if it makes it worse or better. After 2 or 3 days, we have a sense if there's a change in motion. Sometimes he still has the same pain, but he goes, wow, I can move a lot further. The pain's the same, but I move a lot further. And then you go, wow, now the pain's changing. I go to a 4 or 3 level pain. I feel a little bit better. That's what we're looking for in the early stages. But we ask the patient typically to do 1 movement before they leave. after the evaluation, and we see if that movement over 2 or 3 days changes their symptoms. If they feel a little bit better, they don't have as much night pain, they don't wake up with the pain. We monitor red flags during that time. We talked to them about that, which we discussed earlier. And it's based upon them moving their own joints. So it's pretty safe as compared to me aggressively stretching them. I will stretch people at times after I'm sure the movement is safe. But the nice safety in the system is they do the movements and see how they react to it. And they're also, mostly you won't hurt yourself. You'll pull it back before you do a stretch that's hurting you. And that's kind of the safety in the system. So that's the evaluation. We think there's other things that we'll talk about with the clinical exam, and other things that we'll do depending on the person's reaction and what we find in the evaluation. So we're looking for, like we talked about, we're trying to have the patient walk away with one exercise to do before they leave here, okay? And we hope that that abolishes or reduces their pain. Some people are slow responders. They kind of take a while. Some people are fast responders, but I would say after 2 or 3 visits, we have a general sense of it. And there are people who just take some time. And it's not necessarily based on age. It's just some people are, different ways they respond. Next slide. We talked about the safety. You can go to the next. So, like I like to think of it, you kind of walk away. There's 2 approaches. You either you duct tape it or use WD-40. So we're either trying to loosen you up with some stretching, or we want to basically duct tape it. We want to strengthen. You want to get that stable. So that's the 2 approaches. Once you get past the early stages, you'll see a combination of both. But in the early stages, like we talked about, the shoulder extension stretch, forward elevation, and cross are my most common WD-40 ones, the ones that I say, wow, there's a loss of motion. These are the most 3 common, and this one's first. Shoulder extension coming down. You can see it, I think I have it on YouTube now. That's the most common one that will reduce pain. And then after that, we start giving them the strategies as far as the duct tape, as far as the strengthening. So some of the common strengthening exercises you'll see here is shoulder flexor, abductor, external rotator. So a shoulder flexor exercise is typically a forward raise. Shoulder abductor is a lateral movement. And shoulder external rotator is this motion. You'll typically see people lying on their side doing it here. Okay? And that's trying to load those, the theory behind this is we're loading the tendons that have that degeneration, doesn't have great blood supply, we're trying to get blood to it so it starts the healing process. This one always takes longer. It's typically more 6 to 8 weeks, upwards of 12 weeks before these people respond. Unfortunately, the duct tape takes longer than the WD-40. WD-40 is pretty quick acting. You can see rapid changes off in those. And they make you feel pretty cool because you just have someone say, wow, the pain is gone. I've had a friend of mine, Marianne, and she had one exercise. I don't have to come back. I'm good. I said, that stinks for my numbers, but I'm glad you're better. But yeah, and there's other people that take longer. People that take 12 visits, But you typically know within the first 2 or 3 days if they're going to be fast or slow. Next slide. So a couple common solutions I'll give people is the use of a body pillow for the arms and leg positioning. So let's have you lie on your side. I'm just going to show this real quick. Now, I don't have a body pillow. Maybe I have to go to Bed Bath and do this. But I like to have them lie on their side, and we'll get a couple pillows here. For my back pain sufferers, I'll have them put one pillow between their knees. Why not? It can't hurt. Typically doesn't hurt. Take my shoulder. Then you're going to put both arms. If this is the injured side, the injured shoulder, arm in front like this. In this position, the shoulder is in a position that the tendons aren't as stretched. The joint has got the most room in it, and it generally feels better. So I'll tell people to adopt that position. The hard thing is if they're travelers at night and they roll around, they can stay here for 2 or 3 hours, but sometimes 2 or 3 hours allows that person to really feel good and it doesn't irritate them at night. If it's a really inflamed shoulder, you could sit here for the whole 8 hours and you'll be in pain the whole time. It just matters the type of shoulder problem you have. If you have a neck issue, I like to use, there's a little roll in here that's supposed to go right in the inside of his neck. That helps kind of create a little bit of that support for the neck here. Because if some of your pain's coming from the neck and you're not sure, using that roll, especially in sideline, but it's even better lying on your back. Let's try lying on your back. Okay, so this right here, let me just take this out real quick. This right here, I put it in the pillow here, but you rest it just underneath so it creates a little curve in the neck. Some people say, well, I'm not back sleeper. It's most effective if you're a back sleeper, okay? And you place it right about here, rest your head, and this is about where the curvature should be, right about there. So if some of the pain is coming at night from your neck, I'll tell you, try this for a little while. It may actually help you and reduce that night pain that's going into your arm, or even just into your neck. Very simple solution. You don't even have to buy one of these. I mean, these are softer, and we sell these here, but you can take like a rolled up towel and just take some rubber bands and place it in there and find the one that fits your neck. But it's really, if you use it, this is pretty comfortable, you know, so it's just something to consider as far as the night pain. So that's a cervical pillow you could sit up now. I'll tell people to take medications just prior to going to bed, if you're allowed to, certain anti-inflammatories, ice, anti-inflammatories, and also doing some gentle pendulum exercises. Even just some of these people that have had surgery on the shoulder, just gentle rolling back and forth, just to loosen up before you go to bed. Sometimes will decrease the pain that you'll feel at night. So MRIs and X-rays, you don't necessarily need those before starting conservative treatment. In certain situations, obviously you do. You can't just go right to, you've had a fall, you've had sudden loss of motion, you're not coming to me. Should I put in a sling? You've got to be careful about slings because of the frozen shoulder and tightening. So you want to run to that. You don't want to go to the pharmacy and try, or medical supplier and grab those. It's only done in particular cases, and that has to do with a lot of bracing. We talk about whether it be knees or shoulders and everything like that. I'm not a big bracer, and the body needs to move. I want to have movement. If I have a rotator cuff tear and MRI, that is often the cause of shoulder pain. Not always, not always. You can have a neck issue that's giving you a problem, or you just have a shoulder that has a rotator cuff tear, a little swelling, but that's not a pain generator. And the last thing, the screening by a physician is necessary before starting a course of physical therapy. If you have Medicare, unfortunately, you do need a prescription. You need to be seen by a doctor, but you don't necessarily need that. It's not a guarantee of wellness. My typical consideration with people that are coming to me is, if you don't have a response within 1 or 2 weeks, and you're coming to me without a physician, I'll say, you know what, this isn't changing. Why don't you go see your doctor? Even getting blood work. Sometimes you have these systemic problems, rheumatologist, or even just a basic X-ray. So. Any questions? That's our presentation. That's my kids. They're about as big as me now, so I don't know. All right, turn that on.
Is that same beach where you were learning how to surf?
No, that's the beach. I look like that guy. And so, what's that, Jack?
Would you demonstrate again the 10W40 or the loosen up exercise?
Great question. So you want to take the back of your hand. Let's say I'll do this on a kitchen counter or a pulled out bra. I'll step forward with my right foot, if it's my right arm. I'll put this on YouTube for you guys. And you're going to step forward, keeping your body nice and upright to the point you feel like a little bit of a stretch at the end. Pressure on, and then pressure off. You don't even have to step back, but you can. Pressure on, and pressure off. You do this, here's it 10 times, and then recheck it. Is my motion better? Do I have less pain? This isn't guaranteed it's going to help you. It's just, this is one of the most common ones I give out. And I'll tell people when they come to me, check your motion. Okay, I'll do this. That hurts right about there, or that hurts when I reach to there. Okay, do the exercise 10 times. Oh, that's a little bit better.
Yeah.
Keep doing it. Yeah, I mean, it's not for everyone. Other people benefit from crossing exercise, other ones. But you really want to see a cause and effect. It's not an exercise where, wow, 2 or 3 weeks of having more pain and then I have relief. This one is supposed to be immediate.
Right away.
Or at least not worse from doing it.
Right.
And you want to do it even during non-painful times. My general prescription is 10 times every 2 to 3 hours, 2 or 3 days, we should see a difference. If we don't, or it gets worse before that, you stop.
That exercise and the chin, because
Chin
I
retraction,
can't
yeah.
tell exactly where my pain is coming from sometimes.
Yeah, the only time I give 2 exercises in the very early stages,
So
I say,
heavenly. Oh my
yeah.
gosh.
When you have the shoulder and neck, sometimes you're doing 2, because I don't want to not give you something for your neck that's coming from your neck, but it gets harder to tell which one's making a difference.
Right.
But yeah, you try it. That's a cervical retraction extension, which is a pretty good exercise. That's on Facebook. That's actually on a video on Facebook if you want to see it.
No, that's
So,
great.
any other questions? Anything? Okay. Well, thanks for coming. We
There's
also
a questionnaire in the back if you just want to give us a little feedback.
a little
on,
feedback for some
or
topics you'd love to hear about in the
questions
future.
that we can address. We also do discovery visits, so if for yourself or any friends or family that you think might benefit, it's a half an hour with Tom with no treatment, and it's complimentary.
Yeah, we just kind of talk about your problem if you have some questions in a more individual format. And there's no obligation. I'm not going to try and sell you a car or anything like that. I just want to give you some information, just to make a better decision. So it's all right if anyone sells cars, but yeah, but that's basically what the discovery visit is. All right. Well, thanks for coming,
Thank
and
you.
appreciate you
Okay.
spending some time with me.
Thank you. Honestly, I never
Thank you.
asked anything about the shoulder tear or,
I know.
how the shoulder worked. So that was very informative.
We'll be posting on Facebook too, so,
Oh,
Great.
okay.
well, thank you. Grab some, if you want some more, we have some